So in Europe, England, Germany, is this approved for primary progressive?
Yeah, it is approved. And I think based on the experiences in Europe with rituximab, especially from Sweden, it entered the market and it was already a very positive feeling when a approved B-cell depleting agent entered the field. And this is why I think it's also quite frequently used, but I agree it's more used in relapsing remitting patients where it has really a significant impact on the disease course. However, we are now starting more and more to also treat PPMS patients, also because there is a lack of alternatives. And I think also the hypothesis behind to interfere with the B-cell compartment and maybe to get sooner or later more and more B-cells out of the brain is intriguing in my opinion. However, we have a bit of a problem, or we are wondering, when do we stop ocrelizumab in a PPMS patient? Because as already mentioned before, we are not claiming that progression is fully stopped. It's somehow slowed down. But when do we see a point in time to say, okay, in this given patient, the efficacy is not as expected? And this is for me, as in the clinics, quite difficult to define. And I would be happy to learn your strategy when to start ocrelizumab, but also when you think about cessation.
Yeah. Wallace?
So we're using ocrelizumab for primary progressive MS in the UK. So maybe we've had discussions also about this issue around time and activity. And in the UK, active has to have been in the last 3 years. So in order to initiate on ocrelizumab, patients need to have had either a GAD-enhancing lesion or new T2 lesions appearing on their scan in the last 3 years, and also be ambulatory and be in the early stages of primary progressive MS to try and recapitulate the clinical features that seem to be associated with greatest benefit in the trials. Like Sven, I think a big dilemma in treating both relapsing and primary progressive MS for that with ocrelizumab is when do you stop treatment? Because of course over time we're seeing increasing reports of low immunoglobulin levels in patients who have been treated with B-cell depleting agents for a prolonged period. And also we're aware that the pharmacodynamic effect on B-cells lasts much longer than the licensed dosing interval of 6 months. And so whether there's an opportunity for an adaptive dosing or personalized dosing based on, for example, CD19 counts, I think these are all areas of uncertainty with this drug.
So how did they come up with the 3-year definition?
I think that the 3-year definition of activity was just taken as a line in the sand. I think 3 years is not unreasonable. We know that activity is less common in people with primary progressive MS than it is in, say, early relapsing MS. And I think that there are definite risks to this treatment, and you want to try and identify patients who are likely to benefit on the basis of recent inflammatory activity. I think 3 years is a not unreasonable line in the sand.
Yeah, I'm intrigued and often puzzled, though, how regulators come up with these numbers, because they don't necessarily comport with the clinical data that's available.
Sure.
So my experience with this is actually one little paradox, and that is when I'm evaluating a primary progressive patient, and I tell them I want them to go out and get an MRI, they look at me a little funny when I say, and I hope I see a GAD-enhancing lesion. Because normally you don't want to see them, right? Certainly not in our relapsing remitting population. But as Patricia alluded to, there was a hint. It wasn't statistically significant, but there was a hint that if you had activity on your MRI, that you would do better. This was the whole business with Saponimod, which we talked about in a sense, but it is a little paradoxical. I'd like to see something change. I feel a little more comfortable. My experience is that I have some people who do very well on it and some people who don't. And the ones who continue to progress, those are the ones I take off, I stop it. Mm-hmm. If someone's doing okay, I continue it. I think from a pharmacobiology point of view, we still have a lot to learn about B cell depleters, just as you folks alluded to, in terms of the durability of the effect, and even trying to get a better understanding on the nature of the B cells that return initially as they're returning, and whether they may be a more protective population or not. And that will more rationally guide our redosing, which right now is not really done terribly rationally as yet, but lots more to learn with that.
Maybe that's something that COVID-19 is going to teach us, Fred, and that we've got large numbers of patients around the world who are deferring further courses of B-cell depleting agents because of fears that immunosuppression might be associated with a higher risk or of developing COVID infection, or a higher risk of more severe infection. So maybe we're going to start getting some of this data from real-world practice in 2020.
A very interesting thought, because that's exactly what we're doing. We are delaying. We're delaying not only because of the concern of the immunosuppression, but also because of the capacity of our infusion centers to be able to distance people, and so the number of patients they can deal with is going down. And we're trying to limit trips to the hospital or to the infusion center. We should hopefully learn something good from that.